Good morning, dear student. So today I am going to take a lecture on glomerular disease. In the last session we have discussed about the clinical feature, then the management aspect of the chronic kidney disease, and today we will discuss about the glomerular disease. And so what we are going to discuss today, so glomerular disease. So in the glomerular disease, first of all we will discuss about the anatomy of the glomerulus, then the pathogenesis of glomerular disease, where we will discuss the just brief overview of the pathogenesis of glomerular disease, and then we will also discuss about the different clinical clinical pattern of the glomerular disease, and then the we will discuss about the clinical feature of glomerular disease, and we will also discuss about the investigation of the glomerular disease. So we are not going to discuss about the management or treatment part of the glomerular disease, as there are different treatment modalities for different type of glomerular disease, and we are supposed to discuss those things individually. Okay, so today we will learn about these things. In the previous session I have given you some overview of the glomerulus, but let us revise it again. So glomerulus is a tuft of capillaries. Okay. So in our kidney, so you know this structure. This structure is called Bowman's capsule, and this is the PCT, and then okay. So over there are two arteries are coming, and this artery is called the afferent arteriole. In the efferent arteriole, it makes the tuft of capillaries here, This is called the glomerulus, and blood is collected by the efferent arteriole. So this is the afferent arteriole. This is the efferent arteriole. This is the efferent arteriole. And this is the glomerulus. This is the tuft of capillaries. This is Bowman's space. Okay. So glomerulus is nothing, it's just a tuft of capillaries, and if we look the microscopy of this glomerulus, then so if it is the top, it is the Bowman's capsule. So Bowman capsules is also lined by the parietal cells here. These are the parietal cells here. These are also the visceral cells. I will make that thing later on. So if this is the afferent arteriole here, then there is the tuft of capillaries lining over here. So this is the one top of the capillaries. This is another tuft of capillaries. This is another tuft of capillaries. Then this is tuft of capillaries. Then it will. Okay. So this tuft of capillaries is lined by the endothelium. This is endothelium. Okay. This is endothelium. But the endothelium of this glomerulus is fenestrated one, because there is slit here. Okay, you can see that there is slit. There is the gap between these endothelial cells, because there is a gap between these endothelial cells. These are the endothelial cells, and there you can see the gap. So okay, you can see the gap between the two endothelial cells. And there are podocytes, like this type of cells over here, this type of cells here, like these are the podocytes. So the podocytes are the cells of the Bowman's capsule here, and so here you can see the basement membrane. This is the basement membrane. Basement membrane, and the fluid can filter out from this slit, and then ultimately comes to the Bowman's space, and then it goes to the proximal convoluted tubules. Few things you need to understand. So the endothelial cells in the glomerulus are not continuous. There is a fenestration in between the two endothelial cells. There is a gap, and the approximate gap between these cells are near about 4 nanometer. 4 nanometer, so that the fluid and the proteins and electrolytes like sodium and potassium, whose size is less than 4 nanometer, can easily pass through the slit to the Bowman's space and goes to the tubules. But the cells like RBC, platelet and the WBC, whose size is more than 4 nanometer, cannot pass through the slit, the spore. So that is why the glomerular filtrate basically contains the fluid and the electrolytes, and only the small amount of the albumin, because the diameter of the albumin is 3.7 nanometer. But people can ask why albumin can't pass, because albumin has the negative charge, and this basement membrane has also the negative charge, and that there is a repulsion of the albumin by the negative charge of the basement membrane. Okay, that's why albumin can't pass easily through this slit. So the glomerular filtrate contain the fluid and electrolytes because of these phenomena. Then in our kidney there are around 1 million glomerulus in each kidney, mean that there are near about 2 million glomerulus in both the kidney. And so this is the basic anatomy of the glomerulus, and these glomerulus are supported by the mesangial cells. There are mesangial cells over here, okay, extraglomerular mesangial cells is over here. So this is the basic anatomy of the glomerulus. So then let us discuss about the pathogenesis of the glomerular syndrome. So glomerular syndrome can be caused by the different genetic conditions. It can be caused by the different inflammatory conditions. It can be caused by the different vascular conditions, like if someone is having the hypertension, that can cause the chronic glomerulonephritis, especially in a patient with malignant hypertension. Glomerular disease can be caused by different autoimmune diseases. Okay, so we are not going to discuss about these things in detail, but there can be some genetic cause, there can be some inflammatory cause, there can be some autoimmune cause, there can be some toxic cause, and there can be some vascular cause that can injure our glomerulus. Okay, that can injure our glomerulus. So the inflammation of the glomerulus, where there is inflammation of the glomerular capillaries, is called the glomerulonephritis. Okay, it's called the glomerulonephritis. Okay. Then the clinical pattern. The clinical pattern, we need to understand about the clinical pattern. So the one clinical pattern that is the acute nephritic syndrome. Acute nephritic syndrome. I will tell you what is acute nephritic syndrome. Okay, acute nephritic syndrome. Okay, second is easy one, is the nephrotic syndrome. Second is easy one, nephrotic syndrome. It's easy for you people to memorize. Third one is, you can write the pulmonary renal syndrome. Pulmonary renal syndrome. Pulmonary renal syndrome. Fourth one is the glomerular vascular syndrome. Vascular syndrome. Fifth one is acute nephrotic pulmonary renal glomerular vascular syndrome. Sixth one is anti-basement membrane disease. Basement membrane. And sixth one is infection associated. Infection associated. So these are the 6 patterns of the glomerular syndrome, and so we'll discuss it one by one, how usually they present. Like the acute nephritic syndrome is a condition where there is involvement of the glomerulus and patient present classically with the acute kidney injury, AKI. They present with AKI, and the clinical feature of AKI, like in a patient with the acute nephritic syndrome, they can have elevated urea and creatinine. They can present with the swelling of the body, they can present with oliguria, they can present with anuria. That is called acute nephritic syndrome. Okay. So in urine analysis, there is the urine analysis, there is abnormalities in the urine, like when you do the urine analysis of a patient with acute nephritic syndrome, you may see hematuria, you may see cast, you may see pyuria, like that. And patient may have also the hypertension. So if I get a patient who presented with me with swelling of body and oliguria, so on measuring the blood pressure, if patient have hypertension, so on lab test, if I see there is elevation in urea and creatinine, and in urine analysis if I see pyuria and hematuria, so AKI, hypertension, acute onset, then that suffices the diagnosis of the acute nephritic syndrome. This acute nephritic syndrome, some may be some insidious one, acute nephritic syndrome, but some patient may have the rapid deterioration of this renal function, and that condition is called the RPGN, or rapidly progressive glomerulonephritis. We are discussing the acute nephritic syndrome. If someone may have AKI, urine analysis and hypertension, then that suffices the diagnosis of acute nephritic syndrome. And the common cause of acute nephritic syndrome, like some patient with the Goodpasture syndrome, or some patient may be with the like SLE, so sometimes they can present with acute nephritic syndrome. Okay, it may be like sometimes it may, in the rare case, it may be the post streptococcal, different small vessel vasculitis can cause the acute nephritic syndrome. Okay, so then we'll go to the nephrotic syndrome. So in contrary to the acute nephrotic syndrome, patient of nephrotic syndrome can present with the anasarca, but on doing the on examining the patient usually do not have hypertension. They may have hypertension, but usually they do not have hypertension. Usually the urea and creatinine is normal, and urine analysis usually other than proteinuria, we don't see any other abnormalities in urine analysis. There is only the proteinuria. So anasarca, heavy proteinuria, then normotensive, then that make us think about the nephrotic syndrome. Though there can be like rare conditions where patient with nephrotic syndrome may have may have urinary abnormalities and hypertension, but most of the time they don't have. So we will discuss nephrotic syndrome later on. So nephrotic syndrome is basically the primary and the secondary one. Like primary causes for nephrotic syndrome are minimal sense disease, focal segmental glomerular sclerosis, and membranous glomerulopathy, like that. There are secondary cause of nephrotic syndrome too. So in a patient, then the third pattern is pulmonary renal syndrome. In the pulmonary renal syndrome, other than they have nephritic pattern, this pulmonary renal syndrome patient have like pulmonary symptoms like they can have hemoptysis, they can have shortness of breath, okay, in a case of pulmonary renal syndrome, like 25-year-old male presenting with me with AKI, oliguria, hemoptysis, then definitely I have to think about the pulmonary renal syndrome. The important cause of pulmonary renal syndromes is good posture syndrome. Other cause may be sometimes it may be the Wegener granulomatosis. Yeah, so these are the cause for the pulmonary renal syndrome. Then third one is the pulmonary vascular syndrome. If the glomerulus is injured because of the vessels, primarily vessels, then that is called the glomerular vascular syndrome, and classically it occurs in a patient with vasculitis. Like we know there are small vessel vasculitis, there medium vessel vasculitis, large vessel vasculitis, but classically it occurs in a case with small vessel vasculitis like Wegener's or cryoglobulinic glomerulonephritis, Wegener's glomerulonephritis, like in that conditions. Then anti-basement membrane disease, as I have already told that sometimes antibody can form against the basement membrane. Basement membrane, you know, and then it can injure the glomerulus, and classically you will see this condition in case of Alport syndrome or anti-basement membrane disease like good posture syndrome. The last one is infection associated glomerular disease. There are some infection which can cause the glomerular damage, like classically post-streptococcal that usually occurs in children, or infective endocarditis associated glomerulonephritis, hepatitis B and C associated glomerulonephritis. These are the infection which can injure our glomerulus and cause the glomerulonephritis. So we have discussed the 6 pattern of the glomerular syndrome. The number 1 pattern is acute nephritic syndrome. Oliguria, anuria, swelling of body, shortness of breath, hypertension, raised urea creatinine, then cast in the like urinary abnormalities. Okay, these fit acute nephritic syndrome. If such patient have even the pulmonary symptoms like hemoptysis, then it comes to the pulmonary renal syndrome. If patient present with anasarca and only heavy proteinuria, then it fits in the dimes of nephrotic syndrome. If the patient has the glomerular injury along with the other like feature of vasculitis, then it fits in the pulmonary vasculitis. It fits into the glomerular vascular injury. Then sometimes like some genetic cause like Alport syndrome can cause the glomerular syndrome, and last one is it may be associated with the infection. Okay, so these are the different glomerular pattern. So the clinical feature we have discussed now, but when to suspect the glomerular disease. So as I have already to clinical feature can be like they can have feature like swelling of the body, they can have feature like the swelling of the body, they can have swelling, they can have the feature like urinary output, like they can have oliguria, they can like that feature. They sometimes people can have the hematuria, but most of the time they have the microscopic hematuria. So on measuring the blood pressure, they can have high BP. Okay, then we have to suspect the. So most of the urine analysis, we may see the RBCs, cast and WBCs and the pyuria. Okay, so if you see such type of patient, then we have to suspect the glomerular syndrome. So investigation wise, definitely investigation wise, so we have to start from the urea and creatinine. We can do definitely, we can do also the sodium and potassium. Okay, because there can be AKI. Then we have to do the urine REME for routine microscopic, where you can see where you can see the like albuminuria and the cast and the WBC and the RBC we can see. So we have to also do the urine ACR albumin by creatinine ratio to get the level of the proteinuria. Okay, together we have to also test, because there are different pulmonary syndrome, then we have to also test for the antibody testing like classical antibody testing. What we can do ANA for SLE like that. We can also test for the hepatitis B and C. Okay, hepatitis B and C. We can also test for the anti-ASO for post-streptococcal or anti-hyaluronidase. Okay, these are the tests we can do. Okay, then we can also do the complement level. Okay, we can also do the ANCA level to look for the vasculitis. So these are the tests, and definitely we have to also look for the ultrasound to look for the kidney size, and sometimes we require renal biopsy to see the pattern of the glomerular injury. So these are the tests we have to do to diagnose a patient of glomerular syndrome. Okay, so for management wise, we have to discuss all this glomerular syndrome one by one, which is not the scope of this class. If you have any comment, then you can write in a comment section. Thank you so much for your kind attention.